Okay, so hopefully everyone should be able to see that slide now. That would be a good start. So for anyone who I haven't met before, even if it's just virtually, my name's Claire Winton. So I'm one of the ST5 Obs and Gynae trainees in Bradford. I think I've met most of you before, even virtually or by email or in person even. Sorry, I'm a bit croaky. Hopefully my voice won't go completely during the presentation. So myself and Emma were asked to present about postnatal contraception in Bradford, and I just put this very simplistic title of why are we talking about this, what have we been doing, and where, because I think they were the kind of points I was covering as I was going through the presentation. So like I mentioned, Emma, who's also on the meeting, is one of the midwives who now works in the community, who's also been very involved with this work, and both of us together have been part of a large group of people across, well, not just within BRI, because also including Locala, who've been working on this in Bradford. So as we go through, I'll talk about how that's been working. So I'm just going to cover a little bit more about the background of the why, really. And then Emma's going to cover more about the what have we been doing in more detail and how that's being offered. So most of the people on this meeting will know all of this already. So I'm not going to linger on this because this is from FSRH documents, and I'm sure everyone on this group knows it very well. But it's just to highlight why. So we've already mentioned a few things already in this meeting, but so in the UK, it is estimated 1 in 3 pregnancies end in termination. Some of the figures I saw said 1 in 4, but this is from FSRH. And of those that continue, 1 in 3 pregnancies were unintended. So I think, you know, I've been interested in this work for a long time, but when I read those figures, I was shocked. And then 1 in 13 women presenting for termination or delivery conceived less than a year from a previous delivery. So I think that slide on its own gives us quite a lot of reason of why this has been an important area that we've been looking into. But then also, why is that important? So why is it important that, you know, why is it important to look at the birth interval? So there's lots and lots of different reasons. The reasons on this slide are not the only reasons. Obviously, there's huge array of reasons why it's important to look at that. But just from a health point of view, just for the baby, an interpregnancy interval of less than a year increases the risk of everything that we can see on that slide. So prematurity, low birth weight, stillbirth and neonatal death. The WHO recommends a 2-year interpregnancy interval. Now, obviously, that is global, and that might not be the right decision for all women. And some women decide to have children with a shorter interpregnancy interval. But we need to make sure that women have the choice and can make that decision rather than it happening in an unintended way. So moving on to kind of briefly touched on why, but why now? So why has there been lots more discussion about this, both locally but also nationally? Why is this happening? So in Bradford, before the start of the COVID pandemic, we did offer some postnatal contraception, and I wasn't here at the start of the COVID pandemic in Bradford. But it was more on a sporadic basis. It was quite varied. There was no guidelines on discussing it and offering it to all women. But at the start of, in March 2020, the start of the COVID pandemic, obviously we all know that a lot of things changed then. So these statements at the bottom are from the documentation from FSRH. So as we all know, in March 2020, a lot of non-urgent services just shut their doors, and that was quite out of the control of those services. So it was recognised that there was going to be an issue with women accessing contraception, both from GPs and from sexual health. So due to that, this was the advice that came out from the FSRH. They recognised that it might be difficult to access, and they also made the statement at the bottom, which I think is a really interesting statement, that maternity services are well placed to provide effective postpartum contraception before discharge. So I think that's a really interesting sentence and probably covers like everything we're doing, because we are well placed in that the woman or the women are in front of us, but are we well placed to actually provide contraception is a whole other topic of discussion. was another really interesting report. I've only picked out a few little bits, and again, most of you may know about this, but it's worth having a look at in more detail if you're interested. But the all-party parliamentary group published this report on access to contraception in late 2020. It did cover some of the COVID period, but it was actually, a lot of this was to do with pre-COVID. And even pre-COVID, they recognise that there's increasing difficulties for women in accessing contraception, which suits their needs. And this is, again, a huge topic, but this is due to a combination of funding cuts and the commissioning system making it difficult for women to access contraception. And they also highlighted that it's particularly difficult for women from underserved groups. So they've mentioned ethnic minority groups, young women, and women from poorer communities. So what happened in Bradford in March 2020, this may have happened, or it did happen definitely in some other trusts nationally, is that there was a realisation that we need to offer more to women when it comes to postnatal contraception. So like I said, I wasn't actually at BRI in March 2020. I was working in Pinderfields, where there was some discussion, but definitely not as much action as there has been in Bradford. So in March 2020, there was a group of people, including Abby, including Emma, including Kathy Howell, who's not on the talk, but she's also an Obs and Gynae trainee, and various other people who were involved in, essentially, to start with, just raising awareness of postnatal contraception, the need for it, what we can provide in Bradford at the time. There was a big push just for condom provision, which I know everyone on this call knows, not the best form of contraception, but it was felt that, you know, is it something that we can just give to women? And fortunately, at that time, Locala provided us with the condoms to give out to women. And then also quite quickly, not myself personally, but Abby and Kathy ran some education sessions for staff. So that was the start of the trying to train staff up in postnatal contraception. They were informal. I think some of them were face-to-face to start with, and then virtual sessions just to try and get some awareness raised about contraception. And that was the very beginnings of what we've called the Postnatal Contraception Working Group. So that's mainly been run via email. Most of the people involved in this group are working clinically and do this alongside their normal clinical roles, and most of us don't get any time, as we've already mentioned that this morning, but for this in our job. But I think myself and Emma and everyone in the group are very passionate about this work, so I think that's how we've managed to fit it in. Like I mentioned, it's a real mixture. So there's Obs and Gynae trainees, Obs and Gynae consultants, midwives, quite a few gynecology nurses who've been interested, and we've also worked alongside Locala. So I'm not going to go in loads of detail. Becky mentioned about the different guidance that's available, and there is a lot out there, but I just thought I'd, again, just for anyone who, most people will know about these already, but the ones of interest, there's a document from updated in October 2020, Contraception After Pregnancy. And there's also a document from February 21, so even more recent, about provision of contraception after childbirth during the COVID pandemic. And the interesting changes I found in the wording between those documents is, in the first one, essentially it says, there's lots of interesting parts of it, but it says that all women should be provided with contraception and should be offered all types of contraception, including LARC. There's no mention of whether you can provide it or not. It just says you should be providing this in maternity departments nationally, which I was, again, quite shocked by when I read that, because I've never worked in a department that offered a full range of contraception to women postnatally. So I thought that was really interesting to look at that. Then the statement from February 21 may be a bit more pragmatic. It said we should offer all contraception, including LARCs, so implants and coils. But then there was a clause that kind of essentially says in maternity departments that are already providing this service. So it was a bit more pragmatic, but still putting that statement in there that we should be providing the long-acting contraception. In Bradford, we have a couple of pieces of guidance or SOPs. So one is very general on the postnatal contraception, which was April 21, and that Emma's going to cover some of the bits from that SOP. And the other piece, the other guidance that was published a bit earlier was on specifically on coils at the time of elective caesarean section, because that was actually one of the things that we formalised a bit sooner than everything else. So that was mainly Dr. Pettinger, one of the consultants who worked on that. So currently we put coils in at elective caesarean sections, not at emergencies, and not yet after vaginal deliveries. So hopefully that's given a little bit of the background of why we're all here today and why we're talking about postnatal contraception. And I've touched a little bit on what, but Emma's going to deal with the more specifics, the specific detail rather, on what we've been doing in Bradford through this working group. Hopefully you can see the slides, Emma.
Yeah, I can. Are you clicking through them?
I'm happy to click through, yeah.
All right, so yeah, so Claire's already mentioned about the postnatal working group. So the main idea of that group was coordinating various different threads to get the postnatal contraception up and running at Bradford. So obviously contraception provision, so looking at what we can offer to women, formalising those routes of provision, making sure that well, one of the things it's currently still working on is having PGDs put in place so that things like the pill, and also once the midwives and nurses are trained up to do the implants, that we've got the PGD in place so that we can do that without it having to be prescribed. Patient information, which sort of I've worked on with medical illustrations, so I wrote it and the medical illustrations made it look fancy, so we're just waiting on getting those produced, and the leaflets will be going onto the maternity website and being translated into sort of the 5 main languages within Bradford so that women can access that information antenatally. And then banners that are going up into like the outpatient areas and things where patients might be able to see them sort of on their way through the unit. Staff training and education, as we've already know from this meeting, you know, getting that engagement is quite difficult, but we've been we have now fantastically been able to be given, sorry, I can't talk this morning. We have been given an hour-long slot now on one of our care and compassion study days, so a mandatory study day, so we can start giving those postnatal contraception updates to staff on a monthly basis, and then kind of then auditing really to see what women, well, whether conversations are actually happening, what women are going home with, and I'll go into those in a few slides time to show the improvement that we've kind of had. If you could go into the next slide. So they're the 2 bits of information. So on the leaflet on the left hand side and the banner on the right. Next slide, please. So this is the SOP that Claire wrote. So looking at when we have these contraception discussions. So traditionally, we've always spoken to women at discharge, which we recognised isn't really an appropriate time. You know, there's not much privacy. Women are tired. They just want to get home with the baby. So any information you're giving them is not really going in. So we need to start having those conversations early with women so that they at least have it in their mind to consider what contraception, if any, they want to start after having baby. So looking at having an initial conversation at booking, we ask them what contraception they were on before they got pregnant. So it's a great time to just sort of mention, we will be talking about this throughout your pregnancy. So you're establishing at that point whether this was a planned pregnancy, and maybe what the future plans are. And then at 28 and 36 weeks during the pregnancy, when you're looking at the birth planning, great opportunities to give them that information, or at least signpost them to go and find that information themselves. And then obviously the postnatal discussion, and then the GP 6-week check to kind of round that circle off, just to make sure that women have got contraception in at that point. And then at the bottom as well, then any women who are under shared care, so are in the antenatal clinic area, just taking any opportunities to discuss postnatal contraception with women, any contact really, where we can be having that conversation. But then at 36 weeks, women who are being consented for elective section are being given the opportunity to discuss having the coil fitted at section. So for training and education, like Claire's already mentioned, started off with the informal sessions at the start of COVID. We're going to be having a one-off, oh, sorry, there's already been a one-off virtual session with Locala, haven't they? And then there's been junior teaching. The maternity workshop sessions are now no longer, oh, I was going to say they've now no longer got question marks on. I've got the old one in front of me, obviously. We do now have maternity workshop sessions. So midwives will be getting an hour-long update when they go on to that mandatory study day. And then there's the essentials of contraception, which we've, in the first instance, offered out to the staff who sought funding for the implant training, because we felt that we were kind of targeting an audience that was already interested. And then hopefully in the future, if we're able to offer that study day again, we can maybe start getting some more interest. So just upskilling the staff, the midwives, the nurses, to have that discussion, normalising that discussion with women, and giving the staff the confidence to have those conversations with women as well, because that's the main thing, is we need to be normalising the conversations. And yeah, I think that's everything. Next one, please. So contraception provision. So what we already offer, condoms, progesterone only pill, depot injection if a woman chooses, subdermal implant, which we currently have. There's 4 of the doctors, I think, 4 or 5 of the doctors, I think, that already fit them. We've now got one of the gynae nurses and one of our midwives who are both fully trained, and a few more that are kind of waiting in the wings to get their training done. So all in all, I think once everybody who's currently on that training package, once everybody's trained up and running, we'll have 32 members of staff who are trained to fit the subdermal implant. So obviously that will make the provision of that a lot easier. And then the IUD and IUS, which we've said are offered at section. Maybe in the future it might be something that we can offer to women, post uncomplicated vaginal delivery, but I think that's a long way off in the future. So implant insertion training. So various elements to that being able to kind of get up and running. So there's the e-learning through the e-learning for health website, ESRH. 2 of the elements within that training. We sought CPD funding through the education department, which covered the contraception implant training itself, the essentials contraception, and also the letter of competence. So everybody who applied for that was given that little pot of money to be able to go forward with that. And then the practical training, which has been very kindly offered by Locala. But obviously we understand that there's obviously timing and staffing pressures as well to get staff through. So it's not been a super quick process, but it's definitely in the pipelines. So then audit, which has been quite an undertaking, because unfortunately it's been quite a manual task. The audits all had to be done as a retrospective data collection, which has mean we're running reports through Medway, looking at everybody discharged that month, and then having to manually go through and find out what conversations have been had and what, if anything, women have chosen to take home with them. It's getting better, it's getting there, and we are also in the process of having our switch over to maternity Cerner, and we've spoken with the team that have been organising those workflows and things. So hopefully there will be areas embedded within those workflows that mean that audit in the future, once we're running on that system, will be a lot easier. But at the minute, that is taking up a very big chunk of time. So from the audit that we're doing, Abby then very kindly made me this infographic that I can drop all the figures into on a month-to-month basis. So just looking at the percentage-wise of what women are taking home, what percentage of women are being offered or are at least having a postnatal contraception conversation with staff, and then how many staff are going to be, how many of those women who have had the conversation are accepting some form of contraception. So it's just a nice little visual there. So initially, when I started doing the infographics, we were having about 70%. 70% of women were having a conversation about postnatal contraception, and of those 13% were taking home some form of contraception. And then if you just want to go on to the next couple of slides, Claire, so you can see that even just with little I drop things onto our maternity Facebook every now and then, sort of little snippets of information, so that it's in the midwives' minds to maybe have those conversations, to make sure that they're documenting those conversations. And we can see that whether it is an actual increase in conversations or an increase in the documentation of those conversations, you know, we're unsure. But there has been quite a modest increase in the amount of women that are choosing to take contraception home, which is really nice to see. Hopefully that will continue to increase, and eventually our aim is that at least 95% of women will have had some form of postnatal contraception conversation. Obviously, it's completely their choice as to whether they take anything or not. But again, it goes back to education, I think, of the midwives, and making sure that they're confident with the conversations that they're having with women, so that they are able to confidently offer, you know, what we have. So yeah, that's currently where we stand at 77%. Sorry, you've skipped on one. So yeah, in September we were up to 77% of conversations. So what's next? We've kind of already mentioned the PGDs we need to get in place. We need to make sure that the staff that are offering certainly things like POP and the implant, that we've got a little bit more autonomy, that we're not having to wait for things to be prescribed. We know how busy the units are. We know how pushed everybody is. So if we can at least streamline that process, that will hopefully possibly increase provision. M2, who already had an implant clinic in place for women who'd had terminations or miscarriages, we're now looking at formalising a referral pathway. So if any women who are going home from postnatal ward or birth centre who want the implant, who at the moment we're unable to offer because there's maybe no staff around, we can ask them to come back into a postnatal clinic where they can have those fitted. We've got the maternity workshop teaching, which I mentioned. The first one I'll be doing tomorrow. We've got the essentials of contraception, which has been kindly offered, Becky and Amy, who will be running that. And then just making sure that these antenatal contraception discussions are happening, that we're not solely having the conversations postnatally, because that's not the time to have it. We need to start planting that seed a lot earlier. So I will also be speaking at the Community Midwife Forum as well, just to kind of get the community midwives talking about it. I know, having very recently gone to community myself, how much there is to talk with women about, but I can see multiple opportunities where a conversation about contraception can be really appropriately kind of slipped in, and you know, without it being completely off topic. Next slide. So I think that's everything then, isn't it? So that's references and any further resources that have been mentioned throughout. Don't know if anybody else wants to ask any questions.
Thank you, Emma. Well done for doing that after being out at a home birth till 3 AM. Shall we go on to Becky?
Just trying to share.
Got her hand up, sorry.
Yes,
Do you want to ask
sorry.
a question, Smita?
Just not a question, just to Claire, you said that there's like a doctor update that you did in September. Could I ask that is repeated at one of our joint audit meetings?
Yes, it could be. It was done at our, we have monthly teaching sessions which are shared with Airedale now. They're not recorded, but the presentations are uploaded to a Google Drive. But all Airedale trainees are invited to our teaching now.
They are. The thing is that in order to capture maybe more people, including consultants, because we don't get the time to go to the teachings. So our next joint audit is in probably in February.
February, yeah.
I think so, not quite sure, but then it could be just an item on that agenda.
Yeah, I'm happy to, I'll get in touch with you about arranging it. I'm actually going to be abroad, but that doesn't necessarily mean I can't do it virtually, or I can see if someone else is maybe able to do it. But yeah, I'll get in touch with you about that.
Okay, thank you.
Okay, can somebody let me know if I'm sharing properly, because I can't see anybody now.
You are.
Okay,
Yeah,
lovely. So I'm Rebecca Strauss. I'm the contraceptive lead for both Bradford and Kirklees Sexual Health Services, and have been working closely with most people on this call for the past couple of years around postnatal contraception, which has been really quite interesting, and I've really enjoyed it actually, and feel as passionate as everybody else does on this call about it. So I'm going to discuss probably similar things to what we've already discussed, but I'm going to go more into the LMS recommendations, and then more detail about the types of training that are on offer and the costs involved in those training options. So as Claire and Emma have already said, there is lots and lots of guidance out there, and I've just picked out some of the sort of key documents, which I think Claire's mentioned pretty much all of them already actually. A lot of these documents are actually really useful to have to hand and to have a little read of. This Better for Women one is a really nice document to look at. The FSRH document that was done jointly with RCM and RCOG is really useful because that goes through the postnatal contraception options as well. So that's quite a succinct document. And then the APPG, which Claire's already discussed. Essentially, they're all saying the same thing. They're all saying that contraception should be a key part of the maternity pathway, that it should be offered immediately before discharge from the ward. NICE say that women should be offered a choice of all contraceptive methods within 7 days of delivery, excluding the combined pill because that's not suitable. And other documents point out that how cost-effective contraception is. So for every £1 spent on contraception, £9 is saved across the public sector. The APPG report does point out that there is evidence that midwives do feel inadequately trained to provide contraception, and that's one of the things that we've already been discussing, that it's all very well saying provide it, but actually you do need some sort of training to be able to be confident to have these discussions and to provide contraception. And Claire's already gone through the reasons why it's important to provide it, so I won't go through that again. But there's plenty of documents out there to suggest that this is what we should be doing. And then this document was pulled together. We started working on this pre-COVID, and then it kind of got pushed through a bit faster, bringing out some sort of COVID-specific recommendations during the pandemic. But this document is based on national guidelines, and this is the West Yorkshire and Humber local maternity system public health recommendations. So I'm just going to go through these briefly, and I've just picked out the ones that are relevant to postnatal contraception. So a bit of background why this document was developed. Maternity Health Needs Assessment identified that there were high levels of socio-economic deprivation across West Yorkshire and Humber, which obviously lead to poor maternity outcomes. And interestingly, Bradford stood out as one of the areas of greatest priority in the region. So a group of experts got together to develop these LMS recommendations. And there's not just recommendations on postnatal contraception, there's recommendations on all sorts. It's a massive document, but I'm just picking out the bits that are relevant to us today. So this is the first one, which we haven't really mentioned already, but this is just that the discharge summary that's going from maternity should be appropriately timed into primary care so that primary care receive that quickly, and it should be consistent across the system. So these are the main ones really. So all women should leave maternity services with their contraceptive method of choice in place. They should be aware of local services and be able to signpost, and that comes from NICE guidelines. They should work towards the FSRH contraception after pregnancy guideline, which Claire's already mentioned, and fitting IUD, IUS post-birth, which again Bradford have already started doing. Women should leave maternity services with the progesterone-only pill and a pack of 12 condoms at least. And this is kind of a basic recommendation, really. You know, the most basic is providing 12 condoms, isn't it? But the next level is providing POP and 12 condoms. And then the next level up from that is providing a LARC. And certainly high risk and vulnerable women should be offered LARC before they're discharged from the hospital. And with the POP, in the, I can't remember which guideline I read it in, I think it was the FSRH guideline, they do suggest that 6 months POP should be prescribed from the ward, and that costs about £5 to give out 6 months of POP. 3 months is £2.48 exactly. So just more recommendations here. All staff working with young people, women and families should be trained at a level appropriate to their role. And this one is important. All midwives should be trained in essential contraception for midwives. We've certainly had discussions around the reality of all midwives being trained, because it's a big ask and it's a big section of time that it takes to do that course. But certainly we are going to start rolling that out. And even if we can get a proportion of midwives trained in essential contraception for midwives, I think we're doing well. And another one, all maternity support workers should undertake basic contraception training, and I'll go on to talk about the levels of training in a bit. And the last one on here, number 27, which was relevant really, is about the termination services, and people shouldn't leave termination services without at least a conversation around contraception, and preferably their method in place as well. So moving on to training, we've had some discussions around training, and this is kind of what we came up with as the levels of training, as it were. So the first level would be that you'd attend an educational update. A level up from that was you might do the e-learning and plus or minus the contraception counselling course. I think they go together really. And then the next level would be that you'd attend essential contraception following childbirth. And then the next level, letter of competence in subdermal implants. There is further training after this, of course. There's the diploma, there's coil training, but I haven't mentioned these ones because I think this is probably enough for now. So educational updates, as Emma's mentioned, this is the kind of slot that is going to be put into the midwives training sessions over the next year, which is a 1-hour update on contraception. But it could be that you attend an FSRH event, or you could listen to a webinar if you wanted to go and seek that out yourself. So that's more kind of just a general update about contraception, giving you some knowledge about it and making you feel a little bit more confident in discussing it. The next thing that should be offered really, and is quite easy to complete because it can be completed at any time and it's free. So this is a contraception counselling online course offered by the FSRH, and it talks more about how you talk to a patient about contraception rather than going through the methods as such. Contraception consultations are quite different, I think, to other consultations. So where I work in the sexual health clinic, sometimes we'll see someone with symptoms with STIs and we'll take a history and we'll make a diagnosis and we might give them some treatment. And that's what a lot of people do in medicine, isn't it? You know, but with contraception, it's quite different. It's more about discussing choice with women and going through what have they had in the past and what suited them and what do they want from their contraception and what's going to suit their lifestyle. Is it a LARC or is it a pill, or have they had trouble remembering the pill in the past? So it's more around kind of that choice discussion and having knowledge of those contraception methods. So it's a different type of consultation, I think, to other consultations. And that's why this course is quite useful, because it helps you to gain those skills in having that type of consultation. So this can be accessed via this link on the faculty website, and it takes 2 hours and you can dip in and out of it, so you don't have to complete it all at once. Next level up, I would say, is the e-learning for healthcare. And certainly if you're going to do any of the implant training, you'd need to do some of the e-learning for healthcare. And I've picked out the modules that I think would be appropriate for postnatal contraception. So module 3, I'll just go to the next slide quickly, is this one. So I'd say probably the first 6 of those, excluding the combined pill one, would be relevant to complete for postnatal contraception. And then there's in module 10, there's one on contraceptive needs of women following pregnancy. So that's another module that I think would be useful. And then if you were going on to do implant training, you would do module 17 and coil training module 18. So this is all free for healthcare professionals as well. So you just need to register on the e-learning for healthcare site. And they don't just provide sexual and reproductive healthcare modules, they provide modules for just about everything. So it's a great site to be registered on because there's lots of learning that you can do on there. And then the next level of training is what we've talked about today, which is the essential contraception following childbirth, which used to be called essentials for midwives, I think, but now they've recognised that it's not only midwives that could benefit from this, it's anybody working in maybe abortion care as well. So it's not just midwives that would accept onto this course anymore, which is why they've renamed it. So this is a half-day course. And there's some lectures, there's some scenarios, there's some role play, there's a bit of discussion. So it's an interactive half day rather than just a sit and listen half day. And by the end of it, you should be able to describe the contraceptive methods, the advantages and disadvantages of them, learning how to use the UK MEC, which is really important and useful in contraception. When can we start contraception after pregnancy and which methods can we start straight away? And then how do we introduce contraception into consultations? As Emma's already said, there's lots of opportunities for discussing contraception antenatally as well as postnatally. So when should we be discussing that? And then the other thing is bridging contraception. So that's when you might start the POP, for example, but they might want a LARC, but you might not be able to provide it straight away. So you'd start them on the POP and then you'd refer them into another service for their LARC fitting. And we're putting on one of these. So Amy is actually leading on that along with myself and Sally teaching on it. And that is on the 23rd of November. We've already sent around these flyers. So hopefully we'll fill that course. And then what we're aiming to do is put on hopefully a yearly essentials course. And over the next few years, train up a good handful of midwives in the region. There is a cost to this one, so everything I've said up until now has been free, but this does come with a cost. Now Amy's actually managed to secure a bit of funding, which is great, but the cost can be anything from £60 to £165. So it depends on the local fee, but the faculty fee does stand at 20 to 25, so it's not all a local fee, if that makes sense. And then the next one is letter of competence in subdermal implants. And one of the things that has been developed over the past few years by the faculty is the insertion only training. So you don't have to do both your insertion and removal training because it's recognised that if you're fitting them on the postnatal ward, you won't necessarily need to learn how to remove them. So there is a cost to this as well, and I'll run through the costs for this, which have slightly changed since we last spoke about it. But there are some pre-course requirements for this. So you do need to complete the online contraception counselling course, which we've discussed. You do need to complete e-learning for healthcare modules 3 and 17 and provide evidence. And you do need to be up to date with your resus and anaphylaxis and provide evidence of that as well. And then there's some other things that you need to self-certify on, such as giving an IM injection and being able to do a consultation. And you need to read the current guidance on subdermal implants. And then there's another guideline there that you need to read through as well. So you need to do all of that before you apply for your training for implants, or apply and then get all of this done before you attend. And then the practical training we normally run in 2 sessions, more if needed, but we can normally complete it in 2 sessions. You start off with model arm training, so practice on a plastic arm essentially. And then you observe a procedure, so you observe both an insertion and a removal. And then you are observed doing some consultations. So you have to get signed off for a contraceptive choices consultation and a pre-insertion counselling consultation. And then you have to do at least 3 competent insertions and be supervised doing those and get signed off. And the costs for that then, and there's been a lot of confusion around the costs, so I've just popped a slide here, and I'm happy to share these slides with the updated costs, which I did check the other night. So local costs will vary. So Locala are currently providing this at no cost to BRI. We might have to charge an admin fee for some people, but other than that, but if you go elsewhere, you might find it sort of maybe a couple of £100, £300 to have implant training. So they do vary, but there is an FSRH cost as well, and these are the FSRH costs here. So essentially you're better off becoming a member, which costs £94 a year, because then you can get your LOC, which is your letter of competence, for £80, and then your recertification after 5 years is free. If you don't become a member, you have to pay £200 for your letter of competence, and after 5 years you have to pay £470 to recertify. So there's been a lot of talk around costs and funding and how we're going to do this. I won't go into that too much, but those are the outlines of the costs there. Okay, and that's everything. Any questions from that? Just stop sharing. Have I stopped sharing?
Yeah.
Yeah. Yep, Samita.
So I'm going to ask the question about the payment. So you're providing this free for BRI?
So we had an agreement during COVID, Locala and BRI had an agreement that we would train the first 10 midwives for free with no admin cost. After that, that was a COVID thing, really, to be honest. After that, we would charge an administration fee of £50, but we still provide local training for free. So anyone who is local to our service and staying in their role, i.e. not somebody who's moving on, can have free training with Locala.
Okay.
So and that's obviously because the more people we have fitting implants in the community,
less you'd have to do.
It's great for our service too, because it lightens the burden, and the more people we've got out there that have got LARC. So it's a win-win situation essentially.
So I assume that you don't provide, Airedale isn't in your, so we maybe need to have a similar conversation with our local providers. Is that what you would suggest?
Yeah, I'm not sure. Amy, do you know?
I probably know the answer to this, really.
Yeah,
I think
go on then.
the problem with Airedale is that it covers 2 health authorities, so 2 public health authorities. So the patients who are in Craven, so Locala would be responsible for patients in the Airedale area, and because at Farfield we're subcontracted to offer cash services, then in the Airedale area, then we do the LARC. So it would be probably signposting to us for LARCs, but we're not funded for training.
Mm-hmm.
So this is probably something, Becky, that we need to take up with Jo when we next speak.
Yep.
Because it would make sense really that people could be trained locally, and that we could do that on the same basis as those in Bradford, because it's a bit unfair. In primary care we'd have to charge because it takes time, and yet if you're in the Bradford hospital you get it essentially for free. Mm-hmm. So maybe can we take this up with Jo and see if we can have some sort of raise with that?
Yeah, absolutely.
I have a meeting with North Yorkshire in a few weeks. Maybe I'll speak to them about it as well, because it's crazy, isn't it, that we're covering all these different areas.
It's always difficult when areas are geographically split to work out this sort of thing. But yeah, let's have a conversation with Jo about it and go from there. And Amy, you've got your hand up.
Just following on from that, I know I've discussed this with Becky, but the sexual health service, as a district, we've been looking really closely at how we provide sexual health services. And one of the recommendations, the key recommendations from the Better for Women report, the RCOG Better for Women report, is to try and improve access locally and to try and reduce health inequalities, and to improve provision of LARCs at the front door, basically. And one of the main things I want to look at is improving LARC provision. And I think training is going to be a big part of that. It's going to be a big stalling block, and we recognise that. So access and money to help is absolutely essential. So yes, that is one of the things that we'll be working closely with you, Sally, and Becky, and looking at. So hopefully we can try and improve that. But I just wanted to say as well that what inspiring talks they are and what amazing work. You know, there are some really good things that have come out of COVID times, aren't they? And I think this is most definitely one of them. And looking at those audit figures and the improvement and the month by month step in those improvements is just fabulous. And I know from a primary care perspective, we are actually seeing women now discharged with contraception. And I always give a little whoop for joy when I see that on the discharge summary, or even just that discussion. You know, it's so important. And now that postnatal checkups have been mandated again in primary care, that's brilliant, isn't it? Because it provides that bridge until we see them, especially with the vulnerable women who are at high risk of getting pregnant very quickly. So I just wanted to say thank you and how brilliant all this work is. And one more thing, the Essential for Midwives course, I've tried to get some funding through ACT as one, the Better Births programme, and I have asked that that's a recurrent fund. So hopefully we'll be able to continue providing the Essential Contraception course, at least annually. Thank you.
Thank you, Amy. And that's fantastic, isn't it? If we can provide that for free annually,
yeah.
that's brilliant.
Yeah, absolutely.
Yeah.
Thank you so much, Becky, and thank you, Claire and Emma. Fantastic presentations. I've got the recording, so I'll circulate that once I've worked out how to do it. And I really think we should get another date in the diary, maybe for early next year, and get this promoted and try and get as many members of staff from maternity at Bradford and Airedale as possible to attend. Thank you.
Thank you, everyone.
Thank you very much, Abby.
Thank you.
Thank you.
Thanks. Bye-bye.
Yeah.